Good morning, everybody. Thank you so much for this opportunity to the organisers. My name is Nicola. I'm a medical registrar from Cape Town in South Africa. And I'll be presenting a case of a collision of cancer and Candida and cardiac tamponade. So I've already given away the mystery, but this is a report of a complicated malignant oesophago-pericardial fistula. So the story of our patient, a 61-year-old gentleman with a background history of hypertension, who's a smoker, as well as a history of alcohol use. His story began when he presented to his local district hospital with a 2-week history of shortness of breath, as well as some night sweats. His initial ECG showed atrial flutter, and he had multi-territory SD elevation and saddle shape. And with an initial diagnosis of heart failure, with his initial echo showing an LVEF of 40%, but an absence of any pericardial disease or effusion, he was managed with antidiuretic therapy. He settled somewhat and was discharged with the plan for an outpatient cardiology review. However, 3 days later, he was readmitted, representing with progressive shortness of breath and dyspnea. At this stage, there was concern for nosocomial pneumonia, but despite initiation of nosocomial antibiotic therapy, he decompensated shortly within his admission, developing hemodynamic instability. He needed inotropes, and he was admitted to the ICU. His ECG changes persisted. Once he was somewhat settled, he was then referred to our tertiary hospital for a review there. When I saw the patient, he displayed clinical features of cardiac tamponade. He was hemodynamically unstable with low blood pressures. He had low pulse volume. He had raised JVP. He had a pulpal pulsus paradoxus. And this was working in concert with atrial flutter and inducing hemodynamic instability. His chest X-ray confirmed a widened cardiothoracic ratio, and he had left lower lobe compression. We took him urgently to the cardiac unit, where an echo showed a large posterior pericardial effusion, and he had echocardiographic features of tamponade. So these are some images from his echo, and we can see in figure A that there are prominent fibrin strands that can be seen within the pericardial fluid, and that the pericardial effusion is mainly posterior. And in figure B, this is the M mode that shows that there is right ventricular collapse at the end of diastole. We performed pericardiocentesis and drained 800 ml of straw-colored fluid from the pericardial space. And there was rapid return of hemodynamic stability, and he reverted back into sinus rhythm. And based on the analysis of the pericardial fluid, which had an ADA of 47 with lymphocytic predominance, as well as a high LDH, and with a fibrin strand, and we started him empirically on TB treatment for Mycobacterium tuberculosis. Because in South Africa, we are a high burden TB country. TB is responsible for about 70% of all effusive pericardial presentations, and this increases to about 95% in HIV positive subgroups. But there were some atypical features in our gentleman. He was HIV negative, and usually with TB pericardial disease, it's slowly developing, and tamponade is quite a rare complication. He was also negative in terms of PCR, the expert on his sputum, as well as his pericardial fluid. And our suspicions that there was something else fishy going on were confirmed the following day when there was yeast found on initial staining of the pericardial fluid. And later this fluid tested culture positive for Candida glabrata. So based on this and based on the fact that he had an initial acute renal injury, we started him on micafungin, and we stopped the empiric TB treatment. But the question is, how did Candida glabrata creep into the pericardial space? So we had to revisit the history, and we went and chatted to the patient and his wife. And from this chat, it evolved that the patient had suffered from dysphagia for more than 6 months, and he had a long-standing history of heartburn. He also had the smoking history, and with a brewing concern for an underlying non-benign lesion, we conducted a scan of his chest, and this showed that he had circumferential thickening of his esophagus with no clear plane of separation from the pericardium. You can see the thickening here with the yellow arrows, and it's closely abutting the pericardium with the red arrows. We then decided that there must be some sort of unwelcome portal communicating between the esophagus and the pericardium, and so we sent him for gastroscopy. And this revealed indeed that there was a 5 ml defect that was found at about 30 centimeters from the incisors. And here the images from the G-scope can be seen, where the native esophagus orifice with a red arrow can be seen alongside the orifice of the defect with the yellow arrow. And there's inflammatory exudate and foodstuff draining from that defect. A stent was placed over the defect, and biopsies of the defect as well as the surrounds were positive for a squamous cell carcinoma of the esophagus, and they also tested positive for Candida glabrata. So because the initial echo did not show a pericardial effusion, we hypothesized that there was probably progressive angioinvasion and inoculation of the pericardium with Candida glabrata that crept through a fistula that was initiated by an eroding esophageal malignancy. Typically, Candida glabrata is associated with specific host immune defects, but Candida glabrata itself as a cause of pericarditis is quite rare. Just to say that there does seem to be an epidemiological shift with increasing prevalence of Candida glabrata detection in nosocomial infections, with a slight waning predominance of Candida albicans. And Candida glabrata is an interesting cousin of Candida albicans in that it has unique virulence, it has unique immune evasiveness and tissue invasiveness. And because it's inherently azole resistant, it's a formidable pathogen of public health concern. So just to end off our patient's clinical course, he did reaccumulate his pericardial fluid prior to the stent placement, and then he had to be escalated to thoracotomy and drain placement. He settled thereafter and was connected to our palliative care and oncology services. So in conclusions, cardiac tamponade is a clinical diagnosis. Its recognition is life-saving. Invasive candidemia is associated with quite particular and usually nosocomial risk factors and host immune defects. And when you find an unusual bug in an unusual space, it should be interrogated. Thank you.
Well, thank you very much. I have to say that I'm getting angry at our presenters, because we as judges are supposed to choose 5 best, and I don't know how to do it. It's very frustrating for judges. But anyway, Dr. Singal, you are our volunteer.
Voluntold. Thank you for that excellent presentation. And I think one of your take-home points is really, really quite critical in that whenever I'm working with trainees or residents, I'm like, if you see an organism somewhere where you don't expect it, you have to try and explain why. And I think, I always go back to first principles thinking about this, more of a comment, but, infections are either hematogenously spread or direct spread. And so definitely looking for things that are unusual, but you can also expect different microbiology if you have an underlying cause in direct spread. It may not be the usual microbiology. So thank you for that. The one question I had for you was, I note that you had initially started the patient on antibiotics because they came in quite sick and so was on empiric therapy. Do you think this was a monomicrobial Candida infection, or do you think that we suppressed any of the other bacterial pathogens that would also be in the esophagus and isolated the Candida because of the prior antibiotic exposure, and where they continued on broader spectrum therapy, or was it a really targeted therapy that they responded to?
Thanks so much for the question. Yeah, so when the patient was referred to us, we actually stopped the nosocomial cover. So he only had maybe 24 hours of nosocomial cover. I think we didn't have enough evidence at the time that he actually had a nosocomial pneumonia. And it was clear to us clinically that is the reason for his decompensation was a tamponade rather than a septic picture. Of course, we did septic screen on arrival and everything was negative in terms of blood cultures and also in terms of fungal blood cultures to look for fungal bloodstream infection. The question about a dual pathology in terms of the Candida, I think for me an interesting question is whether or not there was an underlying Candida albicans along with the glabrata. Classically, glabrata is like a stealth pathogen that likes to follow in the footsteps of albicans because albicans is like an erosive, more angioinvasive and erosive. And it often sets up a pathway for the macrophage or the intracellular glabrata, which doesn't typically invade but likes to come as a secondary event after albicans. And is undetectable in the immune system because it's within the macrophage, whether or not that can coexist with albicans. But on serial pericardial blood and other tissue samples, the only pathogen we picked up was glabrata.
We have a question.
Just interesting that ferritin has become such an important marker, and your patient was 17,000, and oftentimes you have to look for the malignancy. So that was just one of the learning points that I've had after COVID, where we saw these massive ferritin levels. And again, it's an acute phase reactant that at such very elevated levels, you have to go and look for the malignancy. Well done.
Well, thank you very much. We we came to the last letter of alphabet in our list of countries. Thank you.
Thank you.
We have